talks we took off because of our experience in the last course. A lot of candidates felt that, and we also felt as faculty, that a lot of those things that we were going to cover in talks were better covered actually live in the cases. So the vascular, EUS, basic vascular EUS, where you know where the portal vein is, SMV, splenic vein, etc., artery, aorta, all that we've already done. So what I think, two things that I think are important are obviously about FNAs and FNBs, and the other thing is about pancreatic cysts. So we'll have those two talks today. If there are any questions about any of the things here, then you can always ask. There will be, towards the end, what we'll do is we'll also share how to use secure your system. How are we supposed to be careful? Because like we said yesterday, if your scope breaks here in Pakistan, it goes away for a few months. And then generally most units only have one scope. I'm talking about linear. So I think some experience that I've had over a few years, we'll just discuss that in passing. So without Khalid, we'll start with the pancreatic cyst.
No,
FNA. Okay, so we'll okay. So we're waiting for that to be sorted. In the meantime, are there any questions? Okay, so firstly the needle's trajectory. If it is going straight in the center of the lesion, the likelihood of it is going anyway is less is obviously going to be remote. What happens is that we have the lesion here, the needle is here. So when you try and do that, the lesion will go away. Dusra, you're more likely to go on the side of it. When you've got it right in the center, sometimes you have hard mass, you really have to jab it hard. But if you're right in the middle of the thing, where the needle is coming out, you have to bring the mass, the center of the mass right. The needle should be facing the center of the mass. And then you can jab it. As I said, sometimes when you see things going away, you have to bring it back to where it was, and then the jab has to be sharp. What happens is you're going slowly away. As you're not jabbing, you are actually pushing the thing away. So the jab that you saw some of us do, it depends on the hardness of the mass. That's what my experience has been. So the harder the mass, the quick jab you need to do. Position and maintaining that position and jabbing. And you know that you can't go beyond that. So sometimes you really have to hit it hard. But hit it hard, not slowly. Has to be a sharp jab.
With a force.
With a foot, obviously, yeah. And it's एक jab ये होता है ना, एक होता है आपने ये किया. See, this is where you're likely to get in if it's a hard mass. Usually happens when the mass is hard. Soft mass में नहीं होता. And sometimes when it's a small thing like a lymph node, sometimes they move. Yes. So you just need to make sure that your position is straight. So what happens is, then this is what I do. If Khalid wants to add, he can. When you're using Boston and it's a new one, you generally speaking don't have to do anything. They've already set it up at a place where it will come out nicely. So what I do is I see the needle coming out. If the needle is coming out easily and smoothly, then I have no issue. If I'm advancing the needle and I feel any resistance, then I will take the thing out and have a look at the, I'll pull the needle back, lock it. I'll then advance the sheath and I'll see whether the sheath is actually out or not. And then I'll bring it out and then take it back, usually on the screen. I'll show it to you in one of the cases if we have FNA. Then I'll bring it back, especially when we are, using it more than once, then that sheath is always, even after the first pass, when the technicians actually remove the thing and they take the tissue out, they've already sometimes changed the settings. Do not advance the needle when you feel resistance. Needle should come out from here with ease. Going into the mass, it may get stuck, but it should not get stuck in the scope. So when that happens, I always bring the sheath out, take it back, and I usually do that on the EUS.
What would be the reason of this resistance?
I think what happens is sometimes the sheath comes back a little bit more. So when the sheath is in, the needle is actually gets stuck there. It doesn't come out that smooth.
It may cause damage.
But sheath actually, yeah. Then if you it may cause damage to your scope. So whenever the needle is not coming out, this is what I do. And I don't think that applies so much to them because they almost they only use that A and if you're going to use different needles.
It can happen in the second or third pass.
Absolutely, yes. So if it's coming out nicely, you don't have to worry about it. But if it isn't, then you just bring the sheath out. Actually, on EUS, you can actually see it coming out, and then you take it back to literally the tip. Or if you want, you can also do it endoscopically. But I prefer doing it there. It goes back, then I try, and then I will bring the needle out again. And if it comes out smoothly, then I know that I'm okay. Don't try and advance the needle when there is resistance within the scope.
So yesterday you told us that sometimes when the first pass the tissue is not adequate, so you do a suction technique.
Okay. इसमें दो चीज़ें हैं, two things, right? पहली चीज़ तो ये है कि there are two different things. FNA is different, and fine needle biopsy is different. In Khalid's talk, you will see the difference between the needles. FNA is just a standard needle, okay? So it doesn't have the cutting edge on the side as you have in the FNB. So FNB is biopsy, so it should take a core like we do liver biopsies or whatever in the past. Now, first pass, you get usually in fine needle biopsy, you should get a good core in 8, 9 out of 10 cases. Sometimes when you take the needle out, your technician will say, it's not adequate. The second time when I go, I usually go in. If the first time I haven't got it, I go in with suction. So what I do is, again, that's something that that Khalid told me has been his practice, but he's changed it a bit for FNB. But I still continue. So what I do is I will go in without suction first, make one pass, suction on, 2 or 3 passes, suction off, 1 more pass, and I'm out. That's what we do with FNB. Okay? And then we wait for the core, and if you've got the core, that's enough. If we are doing FNA and I don't get anything, and that quite often happens in small lesions, and if there is nothing that comes out or is not significant, then the second time I'll go and do FN, put a suction, and in that suction, what we do is we go in a few passes without suction, then the suction is on, and we do as much as we want to with suction. So it depends. You want to make 12 pricks or jabs, or you want to make 16, depending on the size. So, one area 4, one area 4, one area 4. So if it's small, you won't get more than 3 areas, so 12. So uski jo first a couple would go without, and then suction is on, and then I would do it without, and then towards the end, last couple, again without suction, and we are out. That's how I do.
This section is done with this specific
There's a,
syringes.
yeah,
They are
there is a
syringes
syringe
and
available with, uh,
three-way.
with most of the needles.
And it is attached with a three-way type.
Yeah, it has
So
attached to
you
the
switch
three-way
it
type.
on
We can show it to you.
You switch it on.
When you, in fact, when you're there this time, you ask them. You can. It has a system whereby you can actually maintain that section. So all you do is you attach that syringe with the negative pressure in it, and all you need to do is just open the three-way thing you have. So when you're done, what you have to remember is when you're applying suction, if you come out of the lesion, then whatever else is there, it will be sucked. So if you want to come out of the lesion, if I'm doing this FNA and I go here and I've done this side, now I can't move my needle to this area, so I have to sometimes come out and use my big wheel, tip up and try and bring it or advance the scope. Once I've got this position which I want, my suction, once the needle is out of the lesion, my suction's off. Okay, so that the negative pressure remains in it, and once I've gone into the lesion again, then the suction will go on again. Because we don't want this area which is outside. When the needle comes out, it will keep sucking whatever comes out, so you don't want that. You just have to keep in mind. If you, sometimes you can actually move within the lesion, sometimes you have to come out and go to the other area.
How many passes you do with the FNA and with FNB?
Okay, FNA, because we do rows, so FNA, I would wait for my technician to tell me if we've got cells in the first pass and there's reasonable tissue in the first pass, then we'll usually take one more. And if that one more is good and he's happy, then we stop. But that would be rare. Mostly it's 3, I think. In our practice, it would be an average 3.
And while you're doing
FNB,
in FNA, when you're doing fanning, how many movements you do per pass? Like in different directions?
so that's what I was saying. If it's a small lesion, so let's say this is what we want to biopsy. Oh, FNA. So I go here, 1, 2, 3, 4. I come out, I go here, 1, 2, 3, 4. I come out, I go here, 1, 2, 3, 4. And if I get a chance, I go here, 1, 2, 3, 4, depending on the size. If it's a very small lymph node you're doing, you can't do 4. So about 12 to 16. But you have to have a system because if you don't have, then you don't know how many times you're doing. It's not. This is not arbitrary. You can do 5, you can do 6 if you want to. But you have to have a number, otherwise it's like uncontrolled. So I think
And with FNB?
FNB usually you need 4 to 6. Don't need more than that.
Sometimes we see patients with biliary strictures
Yeah.
and the CT scan, everything is inconclusive for benign versus malignant.
Yeah.
यहाँ sir EUS
Okay, so in our ward, and it will be nice to know what Khalid's practice is. In our ward, anything that's mid or distal, we go EUS. Yeah, anything that's proximal, then we go SPY.
Easy way to remember is like if it's below the hilum, EUS, above the hilum, SPY, and even in the common hepatic duct, it's a parent SPY.
Yeah, so I would, so we,
Intrahepatic portion of the bile is EUS, anything above that, SPY.
and also you have to remember that it depends on your own expertise, and also because the more you go towards the proximal side of the CBD, the more difficult it is to acquire tissue as well as to evaluate. So you have an alternative. If you have that alternative, fine. If you don't, then. So this is our practice. The lower, but lower CBD, EUS is the best. The lower CBD SPY is very difficult to maintain position.
So it is one of the mandatory indication for EUS. If you find a stricture and you do not find any other supporting evidence to rule out malignancy, so you should go for it.
Everybody who has a distal CBD stricture should have an EUS. Because the CT scan is likely to miss, for example, uncinate lesions. Small uncinate lesions are going to be easily missed. For evaluation of anything that's, वो आप पूछ रहे थे ना, for evaluation indication of EUS, evaluation of pancreatic biliary system, EUS is the best, distal biliary system. Evaluation of submucosal lesions, EUS is the best. The advantage of EUS is twofold now. Not only do you get details about what the lesion looks like or what it is, but you have the option of doing biopsy. Right? Okay. So any stricture in the distal CBD which you are worried about, there is no harm doing EUS. Any mass, any obstructive jaundice you think is because of distal problem, any pancreatic disease, for early chronic pancreatitis, EUS is the best. For CBD stones smaller than 5 mm, 4 mm, which quite often is going to be missed by MRC, is EUS would be best. For evaluation of CBD complete, so whether it's stone, stricture, whatever. For masses, cysts in pancreas, EUS is going to be the best. For liver biopsy, I think it's the best way. Guru, you agree?
I did not listen.
Liver biopsy?
Liver biopsy for that?
For EUS, the patient doesn't have any, and literally any complaint. And it's so simple to do it. I mean, even you have to, liver biopsy is really, really easy to do. You can see liver is the easiest organ to get.
This is an FNB?
Huh? FNB.
So you have done liver biopsy?
Yeah. And patient doesn't have any pain.
Can you do even in the presence of ascites, liver biopsy?
Can you do it?
Yeah, because you don't have to.
No, I mean, can we do it? You think we can?
I mean, percutaneous, no.
No, but I'm talking about EUS.
EUS, I don't know.
I don't see any problem.
No,
Yes, you can.
Because you don't have to.
Can
go
replace
through
the
the
transjugular?
So it should actually. Correct?
Because it
Not only that, but I think it's just we are very. I'm pretty sure someone must already have done work on animal models. I don't know of human series, but I think tips would be done by EUS. Pretty sure sooner or later. It's going to be replaced by. I feel that I don't have the technical expertise in that sense. You know, I must go animal, but I can't see because you can see the whole vascular system.
yeah.
So you just need to go from one to the other. So I'm sure there is, that's what I was saying, the vascular EUS has a lot of, so without any further, so you're going to talk about FNF.
I'm going to talk about different things, a couple of things before I go with the FNF. So liver biopsy, EUS guided liver biopsy, a big topic, a totally separate topic of its own. And there are multiple